Our next speaker is Eric Donenfeld, My Indications from Femto Arcuate Incisions.
Thank you, Ed and Kevin, for organizing this. This is my new slide background I've been working on. And I'm going to be talking about femtosecond incisions. I do consult with a variety of companies who are in the femtosecond space. So I don't think anyone has to be told about the importance of astigmatism, but we have this new thought process that a half a diopter is okay to leave it behind. And I think that we should have a zero tolerance for astigmatism. And the problem is that in the recent ASCRS clinical survey, it's shown that only half of those polled perform manual LRIs. So, you know, we had a conversation now about toric IOLs and LRIs, and clearly toric IOLs are indicated. I don't do LRIs for really much more than a diopter any longer. Toric IOLs are my go-to, but LRIs are wonderful, and especially femtosecond, that they're adjustable, they can be combined at the time of surgery, they don't rotate, and they're best for one diopter or less. So you say, well, one diopter or less, that doesn't sound like a lot, but cylinder is really so ubiquitous in cataract surgery. This study that was published in the JCRS journal, thank you, Nick, showed that 74% of patients have greater than half a diopter, and Warren Hill showed that while 37% of patients have more than a diopter in his study, the low-hanging fruit for cylinder is really those between half a diopter and a diopter. So there's 55% of patients who are coming in for surgery who have between a half a diopter and a diopter, where really LRIs or femtosecond incisions do play a significant role. So the famous and ubiquitous Elizabeth Yu performed a clinical survey a few years ago and showed that the majority of newly trained ophthalmologists really have no experience performing manual LRIs. So how are new residents coming out of residency going to have experience performing LRIs? Well, I would suggest to them that maybe they should start with femtosecond LRIs because compared to manual LRIs, the femtosecond is more predictable, it's more precise, and there's certainly a lot less risk in performing a femtosecond LRI. When I perform a femtosecond LRI, I like to kind of be able to modulate it. So I start with a new laser with different power for my incision. This is one where I'm starting with 2.5. And you can see here that the incision opens up very easily. I don't want that to happen. I want my incisions to open up with a little bit of help. So we'll go back and we'll do another laser on another patient showing a little bit less energy, power of 2 microjoules. And you can see here that the incision doesn't really open at all, so not quite enough. This is kind of like the Goldilocks and the Three Bears system for developing your own LRI nomogram. What I want to be able to do is I want to be able to create a femtosecond arcuate incision that opens with a little bit of difficulty, so I can open one of these incisions on the table, and then I can come back maybe a week, 2 weeks later and open up the second incision at the slit lamp with a Sinskey hook. And here you can see the incision is stuck together, but with a little bit of help, I can open it up just right. So how about the safety of femtosecond incisions? The photodisruption dissipates within 100 microns of the target. It's OCT visually monitored. You know precisely how deep it is. It's a little bit archaic sometimes to use diamond knife incisions that you don't know how far you are from the endothelium. And there's only been one known inadvertent perforation of the cornea with a femtosecond laser, so it's extremely safe. So laser incisions are customizable, they're adjustable. It's no longer really an art form, which is what manual LRIs are, but these arcuate incisions are placed at the exact size, the exact place, and the exact depth. But what I really like about these incisions is that the incision is not really fully effective until the incision is manually opened. So what I do is I titrate my laser parameters, and it's just like a postage stamp. The serrations here really haven't broken until you break them manually, and the full effect can be achieved later on. So you can do it with intraoperative aberrometry on the table, you can do it post-operatively as well, and you get that second bite of the apple of being able to go back and adjust your incision and get a little bit more or a little bit less cylinder. This is a study we presented at ASCRS in 2014 showing that with the ability to open second incisions, we could really titrate our cylinder down to extremely low levels. So how do I decide what I want to do with my LRI? Well, we have this calculator. It's now the Johnson & Johnson calculator, and that was shown previously by Jonathan. And we go in, we just basically insert the information, and you have a choice of my nomogram or Skip Nickerman's excellent nomogram, and then we decide on how we want to treat it, and it shows a picture of exactly what you want to treat. Now, this is very effective, and this is a nomogram that I like to use for manual LRIs on your left, but then we've modified it by reducing the treatment by 30% in patients having femtosecond incisions. Now, all this is a lot of work, and I'm very happy to report that just as of last week, the Catalyst laser is going to be incorporate this directly into the laser, so no more calculations will have to be done. This will all be done using my nomogram in the laser, so you just insert what you want, and it will calculate it for you without all these steps that we've just shown you before. So, how about intrastromal incisions? This is an intrastromal incision. And for lower amounts of cylinder, half a diopter, I think this is my go-to, and I really like these incisions in that they don't break through the epithelium, they're very effective, and they're good for, again, small amounts of cylinder, and this is a nomogram that I've developed using a 6.5 millimeter intrastromal incision. I start 20% below the epithelium and above the endothelium, and probably the most popular nomogram is by Julian Stevens, who's at www.femtoemulsification.com, and he uses an 8 millimeter optical zone. In my experience, I don't get much of an effect at that optical zone, but again, he does the same thing that I do, starting at 20%. I'm going to go back for 1 second. I want to make I can't go back. I want to make one more suggestion in that Julian suggests centering on the limbus. When you have angle kappa and you center it at the limbus, you have the risk that the pupil is a little decentered. You can actually go into the optical zone. So I never center it on the limbus. I always center my femtosecond incisions on the pupil so you don't get into the optical zone. So intrastromal incisions are less pain, no need for antibiotic, less dry eye, greater wound stability, and in summary, I conclude by saying femtosecond LRIs are superior to manual LRIs. They have great surgeon acceptance. They have increased safety and accuracy. There's less risk of flipping the axis. And intrastromal incisions are something we're just starting to use, and they have less pain and no risk of infection. Thank you very much.
Eric, nice presentation. Jonathan made a point that it's important to be perpendicular to the surface when you're using a diamond knife. That's impossible with the femto laser. It's coming straight down, even though the cornea is domed there. Is there an issue? Can you use a nomogram developed for a diamond knife approach or an incision approach? Can you take that over to a femto approach because of this difference in the incision angle?
Kevin, you're absolutely right in that the incisions come at a different angle. It also depends upon what type of laser you use. Some lasers applanate, some maintain the same curvature, and that's why you need to develop your own nomogram. This is a starting point. We've done this nomogram with the LensX laser, we've done it with the Catalyst laser, but every nomogram needs to be adjusted because of exactly what you're saying.
Given if you have the capability to do a regular versus an intrastromal incision, what would you choose, or what's your preferred?
For half a diopter, I will do an intrastromal incision. When I get up between a half a diopter and a diopter, maybe a diopter and a quarter, I use penetrating at those points.
So I noticed with your intrastromal nomogram, it's a 6.5 millimeter OZ. Anecdotally, I've not seen it myself, but I've heard that in a patient like this where they do need to be enhanced with LASIK or PRK, it can have a profound effect when that flap is lifted. Because of that unique intrastromal vertical incision. Have you heard or seen anything like that?
I've heard that. I've actually done this on hundreds of patients without a problem. What I will generally do when I have an intrastromal incision like that, I tend to make my flaps a little bit thicker. So rather than doing my normal 110, I go to 120 micron flap.
Eric, is there an incision length in which you would say, okay, that's too long of an incision? I feel like that's a common question that I get especially with the femtosecond laser, given that it's different architecture, is there a maximum?
Yeah, great question, Priya. And I mean, we used to brag years ago I could treat 5 diopters of cylinder. I like to limit my femtosecond LRIs to a top about a diopter and a half, which is about a 45-degree incision, but I prefer a diopter or less.
So,
Now with the, let's say, modern lenses with, monofocal torics and now multifocal torics, do you see femtosecond LRIs kind of going by the wayside? I mean, more and more, I find, at least in my practice, I'm just not doing as much as our lenses can do, so, are so versatile.
The lenses are our best option. I agree completely with you, Bill. And when given the choice between a toric lens and LRI, I always choose a toric. But I just showed you 55% of my patients are between a half a diopter and a diopter. And I don't see any reason why we should start not thinking about maybe even doing a little bit less than that. So on at least half my patients, I think it would benefit superiorly to a toric lens.
Got it.
Okay, great.
And the last question, what's the minimum amount of astigmatism that you feel like you would treat with a laser or even an LRI? Because there's financial implications in all of this. So when you look at your patients, what's the minimum? You say, you know what, I'm just going to do standard surgery.
Sam, my question will be right back at you. What's the minimum amount of cylinder you put into a pair of glasses?
Quarter diopter.
There you go.
All right.
Okay. Good.
Thank you.
Thank you, Eric.
Thanks. Okay, a little applause, please. Come on.
Oh.